Can you mute that
Recording is on.
someone is on in a motor park? Can you mute others, please? To help.
Check others.
Okay,
Then
gentlemen, ladies, colleagues, junior, senior, cousins,
I know answer.
good morning. Today we are going back to a discussion we started 2 weeks ago, psychoanalysis. So today is a bit different. The title is psychoanalysis, the basic facts. I called it the arts initially, but I changed it because we're not really doing practical things. It's just the facts that are being laid bare so that we can follow. So we're talking about psychoanalysis, the basic facts. And the things we're going to look at is just spend a minute or two looking at what we did 2 weeks ago, just to remind people, because it's really an understanding of this and remembering it throughout would help understand what we're talking about today. We're going to look at psychoanalysis, what it involves, that this section, and one is basic, sorry, and then the other is the work, the how it's done. Then we're going to spend maybe that will go up to about 3/4 of the time. Then we'll spend the last two, well, 2/5 of the time looking at the patients for psychoanalysis. Then we now look at the therapist herself or himself. So that's how we're going to look at today's topic. Last week we talked about Sigmund Freud and how he told us that we have the conscious and I don't know, can we see any cursor? Is it possible? Does anybody see a cursor going around conscious mind?
Yes, sir.
All right, that's beautiful. Thank you.
Yes, sir.
So, thanks. Last week, 2 weeks ago, we mentioned that Freud drew I'm sure everybody knew that there was a conscious self and the unconscious self. So it really wasn't attributable to him, but he acknowledged that there's a conscious and an unconscious part. But what he really brought up is the possibility of having a pre-conscious state somewhere lying between the conscious and the unconscious. So that's how the three levels of the mind was understood by Sigmund Freud, and we talked about this 2 weeks ago. And we also mentioned that Freud divided the psyche into three: the id that operates on the pleasure principle, driven by basic instincts. Remember, we have basic needs, basic instincts. When a baby is thirsty, he cries. That's a basic need. When he's hungry, he announces he's hungry. These are the basic needs, and there are many of the few other basic needs. So these basic needs are integrated with the id, and they express themselves whenever the drive is activated. Then the other one was, I always like using this as a second because it makes the understanding of the id a bit better. Sorry, the understanding of the ego a bit better. Then we have the superego. When children are hungry and they're yelling, when they're peeing, maybe as they grow a bit older, we let them know that you don't go around peeing everywhere. You don't go about soiling everywhere. That's not how life is. We start instilling initially basic values, moral values, societal values, and this all come together to contain and control. To contain, I think is the word, the desires of the id. So that's what the superego does. It tries to let the id know that, I mean, you're not the only person. You do things like we agree. Sorry, not like we agree, like we want. Then there is that ego. That's it operates on the realistic principles. It tries to mediate between what the id instinctively wants to do and what is acceptable. So that's the function of the ego. It balances. It doesn't let the id go around doing anything it wants to, but it knows that there are other people that are the responsibilities and makes them act properly. So trying to contain the activities of the id sometimes brings some conflicts. And these conflicts are mediated, there are inherent ways of mediating conflicts. Conflicts arises because the id wants to pee, and he's being told that this is not where you have to go to such and such a place to do the peeing. Let's take a better example, not better, a more acceptable example. You pick up a glass of water, a cup of tea rather, and it's hot. Earlier on in life, you probably just drop it, but you get to knowing that no, that's not how we do. We contain the pain for a short time and then get something and put it. So this is really the interplay, and it's the id. So it's the ego that coordinates that and makes sure. But when emotional things, when those conflicts arise, fight against what the id wants and what the superego wants, sometimes it causes a lot of stress. And Freud believes that some of the mental illnesses, not all, that's the non-psychotic ones, the neurotic ones, as they were discussed at those times, were caused by such things. The failure of the problems between the control and what the body wants to do. According to him, we mentioned those psychosexual stages. Sometimes one gets fixated at one stage of psychosexual development. Fixation here is that some of the energy is the energy of the libido, that's the energy, gets trapped at a particular stage, and some energy, life energy, is needed to hold it in place. That's a funny way he described it. But that's fixation. So if fixations occur, they can be a source of mental illness. If the failure occurs of defense mechanism, and failure in defense mechanism should be understood properly. Defense mechanisms, we should know at this stage, are automatic subconscious methods that are activated spontaneously and subconsciously to reduce the stress that occur from any situation. Basically, stresses that occur between the activities of the id and the control of the superego. Sometimes when they go against each other, stress occurs. Some other times in real life, things cause stress. Conflicts, approach. I'm sure we remember such conflicts, approach avoidance, all such conflicts. Sometimes that will cause. So the defense mechanisms themselves do not cause the neurosis, according to Freud. It is the excessive use of them that could cause neurosis. That's one. Two, one is excessive use. Two, the aim of the defense mechanism is to buy time for us to use direct coping to the problems we have, to the stress. I tell someone, you're going to fail my exam. The person has the right to use defense mechanism and say, well, I mean, even if I fail the exam, I'm a doctor already, I can get on with my life. Defense coping is, why do you think I'll fail the exam? And I tell you, you're not reading. It's okay, I'm going to decide to sit down, read, and do whatever it takes. That's direct coping. So sometimes when there's a stress and defense mechanisms are activated, and we don't use the time bought by the defense mechanism to solve the problem in a conscious way, directly cope with the conflicts that occur, neurotic symptoms can occur. The third opportunity, the third reason for neurotic symptoms are the intrusion of suppressed content. Still content, some of the things suppressed by the defense mechanism when they intrude into the conscious, either through dreams or in other ways, neurotic symptoms can occur. I need to remind us again that Freud set this thing up at a time when medicine believed that there are organic causes for every illness. I took time last time to mention all the progress that occurred in medicine during that time. So that is when it was. There was no organic cause that could be demonstrated or shown for non-psychotic conditions, for neurotic conditions. Even now, there's no clear-cut hypothesis. Sorry, there's no clear-cut theory that exists. We have lots of hypotheses. Freud had intended that his premise, his methods, his psychology will be useful until specific causes of non-psychotic conditions are identified. Now, let's look at psychoanalysis. I think we need to remember what psychotherapy involves. Remember that many of the psychotherapies we look at looks at the brain as the black box. The brain is not the important thing. Whether you do anything to the brain or not, it doesn't really matter. You can do things to the outputs. You can change the behaviors you see. And if you're able to change the behaviors you see, you treat the person. The person gets healed or treated. You don't need to waste your time going to the black box called the mind or the brain. A child is bedwetting. You use reinforcement and do star charts and stop the bedwetting. A neurotic, in quote, we don't use that term, patient has phobias. You don't need to bloody care what, sorry, I shouldn't be using such dirty. You don't need to bother what caused the phobia. You flood the person, you do implosion, you do whatever else you want to, and you control the symptoms and you treat the person. So in the, especially the behavioral schools believe that you don't need to bother about the core. The outputs that are maladaptive, you sort out the maladaptive things and then get on with your life. But psychoanalysis and psychoanalytic therapies believe that the black box is not a no-go area, that one can find out what is responsible and sort it out. So psychoanalysis is an intensive, long-term form of psychotherapy. I should say psychodynamic psychotherapy that focuses on the identification and resolution of past experiences buried in the unconscious mind that cause distress and malfunctioning. Psychoanalysis believes that there are stress, like I mentioned, core things that are suppressed deep in the unconscious, the subconscious, that are responsible for these symptoms that people have. Okay? It is aimed at fundamentally changing the structure of the personality, not just symptom relief. That's how we need to see psychotherapy and psychoanalysis. Actually, while many other psychodynamic types of treatment aim at symptom release, but in psychoanalysis, the core thing is going deep down. Remember, if you look at how personality is formed, they believe that the school proposes that the fixation of the fixation in psychosexual stages influence development of personality and behavior. So if you are going to alter those aspects of personality that were caused, were determined by the fixation, you need to go all the way back and effect structural changes in the personality. So it goes beyond symptom relief. It also attempts to alter and psychoanalysis. That's what we are going to look at now. Normally, each session is fixed, 1 hour. It can be 2-3 times a week, but an hour is set for it. The setting is usually not on the theater, but on a couch. And the sitting arrangement is so important. You can see in this picture, this is the particular type picture of the couch that Sigmund Freud used. That's how it was. People have tried to analyze the couch itself. But see how the chair is positioned. If the therapist is seated here, there's no way I mean, anybody who wants to turn the eye and strain their neck can do that. Even if the patient is wants to, it's going to be a problem turning all the way to look at the therapist. And therapist himself, which ought to be taking notes, is also the patient is really out of sight most of the time. The patient is encouraged to the patient initiates it. Usually, he is the one who drives the whole session. And like I said, timing is a fixed thing. This is a session in an AI-generated session. You notice that though it is psychotherapeutic, psychoanalytical session, the sitting of the therapist is a bit faulty. You notice how the patient is turning, so they can make contact, which is to be discouraged in real psychotherapeutic situation. Like I mentioned, the couch is a little back, like in the previous picture we saw. The couch, the chair, the therapist is seated a bit away from that, so that distractions and so that the facial, you're not reading stories from the face of the therapist or the patient you're seeing. So this arrangement is set to improve the minimize distraction, focus on the internal, and transference can occur. I mean, if we are looking at the authoritative and the patient is a person who doesn't like such interactions of authority, he might not show the hatred for authority that exists. So the therapist, like I said, the patient's responsibility is to talk, do the talking. And the analyst has a big responsibility to listen. And when you do it, when if you're a good interviewer, a good psychiatrist, you know that the most important instrument the psychiatrist needs is not his mouth. The most important part of the psychiatrist are the ears. Because you listen, you listen, you listen. Neutral, abstinence, you're not giving advice. Your core role is to listen. Of course, there are other things that are to be discussed, maybe fees, what happens with the person. So these are all that the patient should know about before the session starts. We'll spend a few time talking about some of these things. Now, I'm differentiating differentiating when you see the patient before the therapy starts. That is pre-therapy. We are looking now at the initial encounter. There are 7 stages. The first is the initial encounter at the therapy. You establish the framework. We'll talk about that as we go on. The patient is encouraged to say whatever comes to his mind. That's part of it. We'll look at that in detail. You drive into the unconscious because according to the analytical psychotherapy, every all the neurotic symptoms have their roots in the unconscious. Occasionally, there are insights that come up. We'll talk a little more about insight. Then they need interpretation. We're also going to look at transference and countertransference because they are core to therapy, walking through, and at the end of it, there's termination. So these are the different 7 stages. So in the initial, when the patient is coming, not for assessment, we are going to talk about the assessment. We're talking about in the theater itself, on the couch. The assessments don't take place in the couch. They probably take place in the office with the consulting rooms and things. So the couch is where business goes. So the patient is told that the basic thing we're going to do is you say whatever comes to your mind, no matter how trivial, no need to censor. You don't judge it. I won't judge it. Just feel free to go ahead and talk, say the things that come. Remember where the mind is. Remember where the conscious. So you are talking to the patient in the conscious, that we are going to say whatever comes into the mind. A lot of what he's going to say will be unconscious things, but occasionally there are going to be intrusion from the depths of the pre-conscious, sometimes from the unconscious into the conscious. And remember, he has to come to consciousness for him to voice it out. So the royal road to the unconscious is free association. But Freud did not just start with free association. I mentioned 2 weeks ago that he had spent time mastering hypnosis. And initially, it was through hypnosis, but he realized soon that there's nothing the person can say under hypnosis that he's not going to say. Well, not that there's nothing. There are few things the patient would say during free association. There are few things the patient will say under hypnosis he will not say under free association. Usually what the patient says under free association is usually not the effect changes. So he moved from using hypnosis for this to free association. So the next thing is the preparation of the patients to the journey. He's told that sometimes the journey is going to be intense, emotionally intensive. It will be challenging, but it's okay. We'll go on through it. Sometimes during this discussion, there are going to be dreams. If you have them, come with us. We'll sit down together and discuss it. There's also going to be resistance. Sometimes you may want to resist what has come into your mind. Try not to do that. Even if you do that and you notice it, raise it. If I notice it, I'll raise it and we'll discuss it together. Then there's also what we call transference, and there's what we call countertransference. We're going to discuss them in details as we go on. So these are things that the patient is told earlier. So things like trust and initial, you get to clarify those things as you move on with the patient. And it's so important to know that the patient is the core person responsible for many of what goes on. And we need to let the patients know that it is our responsibility. The analyst, on the other hand, is neutral. He's taking notes, not taking sides. He's subjective, not judgmental. He's caring. Okay. And the patient should also know that it's not a short, it's not a 1 day, 1 month, a 3-month kind of thing. That it's going to be slow. And you look at it, something that has been deeply ingrained. Let's say you are attempting to use psychoanalysis to alter some behavioral things that are deeply ingrained, maladaptive pattern of behavior. It's going to go real down and long time to go into the depths of the unconscious. So it's going to go a long time. It's not a short time. It's going to go quite far in time to reach it. And we've heard many doctors, anesthetists, surgeons who group patients or do all sort of things when they're under anesthesia. You know that the council, medical council, or the ethical committees and ethicals don't take that easily. So the psychotherapist has that same level of responsibility. If you are using hypnosis or you're using free association, the unconscious of the patient is to be reverenced. It's so important. We have that same responsibility. It's important to mention that. Now, I've mentioned we are going to spend an hour 2-3 times a week for months, sometimes years, with the patients to dig deep down to understand them. If you are seeing someone for such a long time and you are there listening, open-ended kind of listening, intensive kind of listening, whether you accept it or not, a social relationship develops. You're seeing someone, you're a good listener. I mean, if you're a good listener and you're not in a psychotherapeutic relationship, people tend to trust you, depend on you, rely on you. So that kind of thing develops. So in psychotherapeutic situation, the patient would normally bring to the unconsciously redirects past feelings and patterns of behavior onto the analyst. So that's what happens. So if the patient likes ties and the analyst is wearing nice ties, I stress, she would compliment. Nice clothes, nice. If you understand that in a social relationship, a female who is usually into giving compliments and things would do that. That is normal. It is for you to identify this as the patient's normal way of behaving. It has nothing to do with you. Just the normal way the patient relates that is being brought into the psychoanalytical situation. And the patient has the right. You are the one, you want to know how, when we look at the dig downs of getting the patients ready, you would see how important all these things are, but they come up. They're expected. You look forward to having those transferences, as we call them, or call in therapeutic sessions. So it's desirable. What the purpose is for the psychoanalytic session to work through it. It's not up to you to utilize it or do anything for it. No, it is not there. It's not a threat. It shouldn't be a disruption. It's expected. If it doesn't show up, then you're not going deep enough with the patient. The one that is of problem is called countertransference, where the analyst brings into this therapeutic relationship emotional. Please, can that person who is babysitting wake up? So the analyst sometimes also unconsciously brings emotional reactions to the patient. This shouldn't happen. You are talking with your patient. You have clinical responsibility to the patient. If you want someone to listen to you, go look for your own doctor. And countertransference shouldn't occur. And patients, the therapists are expected to get their own doctors and do all the transference, that to the court transference like that during their own sessions, not to bring it into a session they are in charge and responsible. Now, there's what is called resistance. It's an interesting concept and it's difficult to find out. Please, can we? So there's what is called resistance, and of course, it's expected, and it has its therapeutic values. So resistance are usually clients or patients' unconscious opposition to exploration and interpretation of painful memories, repressed memories during therapy. Sometimes the patient can show it in many ways. He can be silent. He can look the other way. He can try to rationalize things or intellectualize it. It's okay. It doesn't really matter how you hope to have resistance, because it is having resistance that makes you know you are getting into the patient. So the purpose is not to resist. The purpose is not for you to overcome resistance. No, it is for you to understand resistance. You are getting resistance. It should make you know that the patient is into the therapy properly. He's having the unconscious things are coming up, and he's resisting. So these are the desired things, and we look forward to having this resistance. And sometimes insights, when the insight occurs, and in psychoanalysis, it is beyond mere intellectual understanding. I hate my dad. I don't hate my dad. But if that is what your patient had presented with, and he didn't know why he hated his dad or hates his dad, and suddenly, as he is exploring his unconscious, as you are listening, because you are the one doing the listening. You are not really probing into the unconscious. You listen. You can probe much later, but initially you are harvesting things that come out of the unconscious. So insight is not just mere intellectual understanding of what happens. It refers to deep, often emotional and unconscious origins, a dynamic realization how one's conflicts, symptoms, and patterns of behavior, has roots in the past. That's what we're talking about. While intellect, well, that's the core thing I need us to know. And yeah, so sometimes it allows the patient to see how these unresolved conflicts or early relational dynamics continue to play and have effect on their adult role. Like I mentioned, good example, the guy grows up hating the father. And as you're digging down backwards, you gradually, encourage the patient to bring up things that are important, that are relevant. And as they are talking during free association, I mentioned is that royal road to the unconscious. Things start dropping in. Let's say, I don't know how many of us understand how borehole functions. Remember, if you dig a borehole, you don't reach a well, you don't enter a well, a body of water. No. The opening created by the borehole allows water to seep in. So the seepage is like that free association. You are in the relationship, you are giving the patient, let's say you're not digging into the tunnel, but the road, remember the picture I showed of the road that links it. The vacuum is opened up by the free association and things seep in. So that's how it does. So when things seep in, sometimes the patient sees intellectually, oh, my dad slapped me one day and allowed me to be beaten by a girl. Yeah, but that may be remembered. That is not insight. That's just an intellectual understanding how important that is. Insight comes with lots of emotion and stuff. And it's an important thing. It's one of those primary mechanisms for therapeutic change. That is during the understanding and the discussion of the things that the patient has inside. It's usually one of the core ways that one of the pillars of psychoanalysis is the identification, understanding of insight, and how you help the patient, how you guide the patient walk through it. So insight is the beginning, and it is the places when they're called, the process of walking through really starts. The patient may interpret, offering some hypotheses about how the meanings are linked to it. Yes, it's best if you allow the patient to be the one who shows how important it is. If the patient is not showing, maybe it's too early to interpret. It's not everything you pick up during the psychodynamic work that you interpret. You let them stay. You could do the best is to reiterate it. Say, okay, you've said this. You state what the person says, and the person acknowledges. You note it. Some people, when they end the session, they do they do a summary of things that have come up during that session. Sometimes when they're starting the next session, they do a recap of things that have done. Those things are just to keep the things. You're not going deep into explaining, but you repeat it so that the patient remembers it. The next day, it can also come up. Now, if you start doing interpretations too early, it's not okay. Interpretations are delayed and wait until the patient is ready. Remember that you may get insights, or insights can come up like we mentioned in the other slide. if they notice that problems with defense mechanism, transference may occur, underlying conflicts may come up, any of the things that come up, it's important to note them. Early in the therapy, you just note them and reiterate with the patient. But each time, as you're summarizing, you mention some of those things so that it is still there. And sometimes when you are summarizing and mentioning, even if the patient wants to start describing it next, you reassure him that next time we will start with that. You understand? So that you stick to your 1 hour. When they come next time, you are mentioning all those things again. And you tell the person, there's no need discussing of these things now. I'm just reminding you that these are some of the things that we found earlier on. So when the time comes for interpretation, then that is done. Walkthrough is that repeated revisiting and re-examination of insight, resistance, transference over time, trying to get them integrated, getting them integrated into the change that you expect from the patient. Now, after you've gone on with the patient, I told you it's quite easy. It's not in 60 years or more. The termination will eventually come, and it might be best if the patient raises that, oh, I didn't need to be able to function in this situation. Now I'm getting ready with it. If the patient doesn't bring it up, the patients who had I don't know what good example to use, could mention, oh, I'm no longer having this. You understand that. If it's too early, don't be in a hurry about terminating the process. Depending on what the end was, if it's just symptom reduction or symptom change, yeah. But if one is planning to go deep into changes in the personality of the patient, too early an interpretation is a disadvantage. So if the patient has, after some time, realized it, mentions is functioning well, and there has been adequate interpretation and insight and stuff, then it might be time to consider winding down the session. Even although it is the patient initiating it, it doesn't mean that when the patient initiates it and in 2 sessions you wind down. It takes a few sessions to gradually wind things to an end. Months in advance, actually. So during this time, one is now being prepared for the ending of the session. Past gifts, money, dependency, and things are also mentioned. It's important to gradually wind down the session, because if things don't get wound down, people can develop what we call dependence on the patient or on the therapist. Some people can develop grief, what we call separation anxiety and stuff, if the termination process is not done well. So remember, it's a social relationship. The person may accuse you of being served breakfast. If some of you know, I'm sure the younger people know what being served breakfast means. So it should be done, planned, and gradually brought up. That's all I'm trying to say. Yeah, of course, the last days should be spent reviewing all the things, consolidating the gains. So these are the things that should be done. Now, there's a funny question people always ask: are there follow-up in psychoanalysis? The answer is no. There are usually no follow-ups. Or, let's be nice, sometimes they can occur if you are needing referral from a patient, or if you're needing, referral, if the patient needs some referrals and stuff. Emphasis in psychotherapy, in this type of psychotherapy, is aimed at independence. The person has to be independent, has to move on, go on. So that's the termination. There's no follow-up allowed or expected. If someone wants you to write some medical referrals or something, that can be done, but not reopening the therapy. Now, we'll spend the next 15 minutes looking at other things. well, it will be 15 minutes, we make it less. Which patients are suitable for psychoanalysis? Every patient who has non-psychotic conditions, every neurotic conditions, no. There are active things you are looking for to be present. Now, there should be something that are chronic, pervasive suffering caused from deep-seated, enduring distress and impacting on several aspects of life. You know, the treatment is costly in time and energy and intensity. You don't just jump to it on everything. The surgeons now tell you that there are certain medical management of conditions. It's not everything that we're going to push someone on the couch for. It has to be worth it. That's the point I'm trying to make. So the patient has to have a neurotic condition that is causing enough, long enough, or has caused enough suffering for it, and it's affecting many aspects of his life for there to be a good indication for psychoanalysis. It should be things that are neurotic or character, deep-grained things that are that deeply ingrained, and that there are no other psychodynamic or other psychotherapeutic ways to use in resolving. That's when you consider psychoanalysis. Now, the patient himself has to be psychologically minded. So psychological mindedness is an important thing, very important thing. Now, there has to be capacity for self-reflection. Someone who is not able to look inwards is not going to be a good candidate for psychoanalysis. The person should also be able to tolerate frustration and anxiety, and to be able to tolerate discomfort. Remember, I mentioned that the psychotherapeutic relationship is an intense one, and sometimes resistance may occur, and people who are not able to take some level of discomfort and frustration may have a lot of difficulty tolerating psychoanalytic intervention. It is like opening up your dirty bag in public and things like that. So only people who can take such, or who have enough problem and enough distress or interfering so much with multiple areas of their life are the ones who should be allowed to go through this. Okay, it's also important to get people who are able to understand things about abstract and metaphorical reasoning. People who are curious and have some level of insight, desire a lot of insight into what's happening to them. People have strong ego strength, good reality testing, impulse control, be able to talk. This is the basic things. People must have good insight and check. What I'm really saying is that maybe we should see a situation where people have many masks. I think that's how we should look at it. Your patient has many masks. Like people believe that people have many faces. There's a face they think they have. There are faces they have when they're alone. There are faces they show when they're with relations. There are faces they show in public. So you need to, if you are trying to check out the patient who qualifies, check what kind of face your patient is really having. That is the different mask the patient is wearing. You need to be able to tease them out to understand if the patient you're dealing with can really cope with psychoanalysis. There are a few contraindications, and they are really significant. So luckily, nobody does psychoanalysis. It's so rarely done that you probably will never have to do it. But there are lots of people who don't qualify, who are really ruled out from start. People don't have good, in psychotic conditions where there's poor reality testing. I don't think any of us would think twice about, would consider bringing a psychotic patient to So most times, I don't think we'll have such a problem. Yeah, so what we should really look at smaller things that can be confusing would be the people looking for we don't have it done so much, so maybe we shouldn't really bother about the contraindications. I mentioned lots of things about the mask. Okay, so in getting your patient prepared for psychoanalysis, we have to look at each of the faces the person has and tease them out. Some people have only one or two, some may have a few masks. So the point of preparing patients for psychoanalysis is to identify which each of the masks they are wearing. Okay, so basically, we say it is full history. Many psychiatrists, residents, doctors, and psychiatrists think that they have gotten the full history when they have sat with the patient and talk enough and make diagnosis. We even call it psychodynamic formulation, which is joke, because it's only in psychoanalysis do we really truly have psychodynamic formulation with patients. So maybe, well, many times we just call it diagnostic formulation, but psychodynamic formulation we would see again is identifying each of the masks the person has been wearing, discussing how they come up. So this is the kind of level we need to go into when we are doing a comprehensive data gathering and full history. Thorough clinical interview goes beyond standard psychiatry. It involves exploring the patients presenting consent in depth, delving into the developmental history, early childhood, family dynamics, significant relationships, inner world, dreams, fantasies, current circumstances, the affects, communication style. That is the kind of depth we are talking about. So it's a serious thing. This is not done when the patient is on the couch. I have to stress again. These are normal things done in the office where the person is in the consulting room. You don't prepare someone for psychoanalysis in 2-3 sessions. That's actually the point. You sit down with the patient, dig as much as you can. Of course, during free association, some of the things you try to find out will come out, but you have to dig adequately into the patient to identify which, if this is the real patient or it is a mask. If you look at, there's no point looking at the picture. The people wear all sorts of masks. Even this thing we are seeing as the color of the guy may not be the real thing. Okay, so if there are past records available, previous psychiatric evaluations, notes, all the things, we get them. Certain information is required from some, all the information that's available, we're expected to. This is the opportunity you have to use the projective test. So which one do you know? Have you mastered? Result? Any of the tests you expect to be used. The personality assessment that is required here is beyond Big Five. One has to go deep and using MMPI and understand it may help show where the issues are. These psychological tests are not replacing what you're going to do on the couch. These are things you find out before. Of course, whatever you get in the assessment, you'd hope they'll come up in the couch. If they don't come up in the couch, you have not gone far enough. Okay. Then next thing after the objective test and the personality test is trying to do a formulation of the central conflicts. Remember that the indications included that there must be specific conflicts or things you are after. So you see the central formulation. So we identify the core. You uncover unconscious conflicts in the office. understand the previous defense mechanisms, all that are mastered and done in the office before the session really starts. You're also expected to look at the ego strengths and weaknesses of a person. We mentioned reality testing earlier on. How accurately does the patient perceive and interpret internal and external reality? Impulse control, affect what is the patient's capacity to explore and regulate his range of emotions. Object, how mature and integrated are the patient's representative of self and others? Can they maintain stable and meaningful relationships? They need to be able to before they can actually go into therapeutic relationship with you. So these are the things we go in depth and find out. These are things, and I said it takes weeks of sessions. And if you are not able to have come close to obtaining all this, at least making inroad into them, it might be a problem of relating with the patient. I mentioned earlier that at the end of this, you are expected to do your psych. This is where the true psychodynamic formulations, all the information you gleaned from all that, you are able to now analyze and do a proper psychodynamic formulation. How does the patient see symptoms? How do the symptoms relate to the underlying conflicts and ego functioning? Of course, you do your ICD 11 diagnosis as you think, but what is of interest here is to look at those broader things, psychodynamic understanding, neurotic, borderline, narcissism. Those are the things that one is expecting to come up in the psychodynamic, to also come up in the psychodynamic formulation. Differential diagnosis here would also be more on psychoanalytical kind of psychodynamics, not the ICD kind of thing. We're talking about the mind now, the psychoanalytic kind of psychodynamic formulation. All right, in the next 2 minutes or 3 that we have, 5 minutes that we have before we finish, it's not only patients who have many faces. What about the therapists? So we're going to take a look at maybe one or spend the next few minutes trying to see if a therapist who doesn't know who he is, hasn't started, cannot really be a therapist who has not identified himself, come to terms with himself, cannot really help himself or any other person. So before you consider going to psychoanalysis, you need to get formal help in understanding and knowing yourself. So in conclusion, we are going to now look in analyzing oneself. So self-analysis is cornerstone of psychoanalytic training. It's rooted in the belief that an analyst must deeply understand their own unconscious processes to effectively treat others. It's not just about intellectual understanding, but a profound personal experience. We don't stress this in training in psychiatrists anymore. But the older psychiatrists, the people who have really understood and gone deep into psychiatry understand themselves. And even if you are not going to do psychoanalysis, but if you are really going to do any form of psychotherapy, this is where drugs don't matter. What is effecting a change is the interaction between you and the patient. You don't need to be a psychiatrist. Anybody who is going to use himself, you are putting yourself on the line, the quality of your intervention before you can help others. In our introductory lectures, we were told that the person doing the psychotherapy is probably the most important factor in any psychotherapeutic intervention. Two people may do the same things, one person gets results, the other does not. So it is not what you do, but who you are that is core to getting effect. You remember, I don't know whether it has changed when we were residents, the psychoanalytic therapy, psychoanalysis was the difference between it and behavioral therapy was no, I think for all and the doctor that brings cure. So a doctor, a therapist, whether you are a doctor or social worker or psychologist or nurse, it is you that is interacting. So if you're not even sure which of you, if you have different faces, remember what we just showed. You need to know who is real you and which of you is going to interact with the patient. So it's so important to understand yourself. You may need help in understanding oneself. For psychoanalysis, the candidates who are the trainees undergo self-analysis. Self-analysis does not mean that they analyze themselves. No. They go through psychoanalysis themselves. They have a therapist, resistance, the transference, the countertransference, all that comes up. And it is only those who are able to know themselves to that extent who are going to be able to effect changes in others. Self-analysis is also important because it makes you understand the technique. This is the second thing I'm talking about. The other one is to know who you are. It also helps in making people internalize the psychoanalytic techniques. They learn how to address personal issues. When they see patients have resistance, they would remember when they had resistance themselves, when they are transference, and they would also know. That way it helps them keep their countertransference better to themselves. And self-analysis is not just a once or a 1 year program that you do. You indeed go through it periodically to continuously know who you are. It helps. Why it's important to do this self-analysis is that it prevents projection. If you already know yourself, you're not going to start projecting yourself on the patients. It helps manage possibility of counter-transference. It makes you see whether you're doing proper listening, ethical foundation. It's actually the core of any form of therapeutic interaction you are going to go through. I'm not saying that it's not only those who are going to do psychoanalysis who are going to understand themselves. Each of us who wants to do any form of therapy may know. When the AJ was giving a lecture last week, one of the questions was one of the people asking the questions. Two or two different people asked about the same questions. Sometimes when you are with the patient, sometimes you are. We'll talk about motivational interview. There's a power dynamics between you and your patient. The patient comes for therapy. There's that dynamic. You haven't come to terms with it, and your patient is who is lower in the power dynamics is saying something to you. Anger wells up as it would. Those are things that are not expected in therapeutic relationship, whether they are psychodynamic therapy or other therapies. So it's important to know yourself before you move on to other aspects of psychotherapy. So thank you, gentlemen. Thank you for giving me the whole hour, and thank you.
Thank you very much, sir. We are most grateful for your wonderful, wonderful reintroduction, depth to what psychoanalysis is, and you have taken us from 2 weeks ago, the genesis, and now we are the arts.
Congratulations.
We are really grateful, sir. I'm sure people will have questions and they will bring it up subsequently. But as a way to keep the process moving forward, thank you. Please keep the uploads. Please keep it coming. Thank you very much, everyone. One of the things that came to mind, sir, is that as you are presenting it, it brings one of the related phenomena that is there also the psychodynamics that often people took or misinterpret in an otherwise with different understanding is the concept of when the patient have challenges and say let's do insight oriented therapy for the patient. Often people misunderstood it to imply whether psycho education or just to do any form of emphasis on what insight means. But the lecture you have given, I've come to try to bring it to the fore. Why insight-oriented therapy is also a psychodynamic therapy, that it takes more to do, it demands more from us. Anyone that wants to do it, the expertise that is needed, and what the individual will be expected to be able to bring to the fore, and the ability of the individual, especially when you're talking in the area of insight. Because when you come to that area of insight, then that keeps coming to mind that this is part of what we fail to appreciate, and often we misinterpret and quick to jump and call it insight-oriented therapy. Whereas we are not doing it because we're not following the psychodynamic principles. We just assume, we do it, we talk that please refer, and we get some reports, but the patient never really have insight into their problem, because you brought it that when the patient have that insight, that's when therapy begins. And that is what I thought part of what insight oriented therapy is about. So that to allow the patient to get to that depth so that the therapy can begin. So that more opportunity for recovery that the patient needs can actually comes to the fore and bring. Of course, some alternative might be psychoeducation, and some other things maybe motivation interview to help get the patient to insight. But insight already seems to be far and wide apart from that. And thank you, sir, for bringing this up. It's one of those things that keep coming up every time you tell people that no, insight oriented therapy is what you are doing. People turn it to something about it. This have helped to help us expand it and show that yes, it is a whole different ball game. If one door is not psychodynamically minded, and it would be difficult to be able to offer it insight-oriented therapy. Thank you so much, sir. That's one of the things that came to mind, and I said, sir, let me briefly share that with you, and I'm sure you have more comments to make on that. Why this is there, please, like we say, please just show your interest or unmute yourself and ask question, make contribution. Please, is the floor is open for more comments and contribution to it. Thank you very much, sir. And thank you everyone for participating.
Good morning, sir. Thank you for the lecture. Now, please, my question is talking about social interaction with the patient. When we are conducting the therapy and even after the therapy, how do we relate with the patient? Knowing fully well that the patient has shared a lot of personal information, and this might be somebody that outside the session, normally, we have some interactions with. How do we negotiate this challenge? Thank you.
I don't know how do I put it. I don't know whether there are no relationships that should make psychoanalytical relationship. I didn't put any of relationship as contraindication. how do I put it? You know, doctors say you shouldn't treat your relations, which is not really true. I've treated, well, not because I do it. You can treat your relations if you can, but I think what it does is takes a little extra care because of all that things. So if you can get help, you may, if you fear that, how do I put it? I can imagine you're making me look straight to the most difficult part. You have a girlfriend or a guy friend, what do you call boyfriend, and you are doing psychoanalysis of the person. I don't think it's going to work because resistance, that's what I think. So it's going to be a problem from start. And I'm even daring anybody. I mean, if I know anybody who went into therapy with another, then the therapeutic relationship ends and the person is making use of the things he gathered from the therapy to relate to them. You understand what I'm really trying to say? I said that the unconscious mind is should be, it's a word I use, reverence or so. It's the sanctity, yeah, that's it. You get what I'm trying to say. Under hypnosis, under psychoanalysis, you identify something that had happened. Maybe someone had stolen, let's just use a raw example. Someone stole your car, not even car, someone stole your something you had loved so much. And then the person comes for you to do psychoanalysis. And during the analysis, you now discover it was the person who stole. That's what we're talking about, right? That's a raw example of what we're talking about. What's your, how do I put it? You're under oath as a doctor. You're under oath as a therapist that you cannot, that's the wrong person for you to do analysis of. You can break the, even if you break the relationship, you are still under oath. I don't know if I'm making sense. Even if
Yes, sir. Yes, sir.
the relationship ends, if you now reach a point and you say, look, I'm sorry, I can't continue this therapy with you. Then you come out of it and think you freed yourself from doctor-patient relationship. It's a joke. If the patient talks to someone like me, I'll tell the person to report to medical and dental counsel and would make sure that the consequences you get. So these are the points that it's not everybody you must do therapy to. You get what I'm trying to say? It's not every person you should agree to do psychotherapy with. I have friends who, when I tell them I do hypnosis, they want hypnosis. I just smile and say it's a long time I did it, and I don't go into it. You understand that there are things that you can. So let's go back to therapists. Know yourself. You are not going to be able to handle what you get, then don't start. I think that's that's it. You don't start. You know that people who talk like this are my weakness. Oh, this girl looks like someone now. I mean, I have fancy. No, that's not a patient for psychoanalysis. So for long-term psychotherapy with. I don't even know whether I should do any psychotherapy with such a person. So analyze yourself, understand yourself, and this thing you want to start, are you sure you can handle it when the chips are down? And I think that if someone has gone through self-analysis properly, it would help you choose the patients you're going to do analysis for. And you can refuse to see a patient and let another doctor see the patient. And please, if someone refers a person to you for psychotherapy, the doctors share information. We know that we share information. We must share information for training purposes and for management purposes. But the information you share you must get clearance from the patient to share it. I think it's only where it matters to life, threat of life, and I think people have added property now, that one is obliged to share certain information. But that's, you get the point. So sorry, I can't help, but we are expected to understand ourselves and know which mask we wear. The mask you wear, are you going to be able to tolerate certain things that you're going to hear from this particular person?
Uh,
Yeah, I think that's, thanks for stopping me. Thank you. I'll just
Sorry, sir.
show you what
I just want to add to that. I think maybe a question might also come in the area of boundary setting. I don't know if you want to comment on that. The boundary setting in psychotherapy, sir. So maybe the guy will also guide the relationship aspect of between the therapist and the patient. Yes, sir.
my understanding of this question, Dr. Abiola, is boundary setting uh, occurs in people you meet. That's not that, but I'm trying to make us look at it like that. You meet someone, maybe let's not use a good example. Let's use a bad example. The person is a managing director of Dangote refinery. I think that's the most precious thing in Nigeria these days. Or is it NEPA? And because you have this interaction with the person, you are making demands like, can I come and get fuel? I think it's not ethical. Yeah, that's old school. You are doing therapy with managing director, some managing director of someone. You now ask the person for contract. I think this is the sort of the ones I'm more interested in boundary setting. It's unethical. Yeah, it's unethical. It is old school. Many people would reason that God has given you a blessing, that He has brought someone in charge of employment, and your wife needs a job. You understand that it is not respecting the person's unconscious. It's unethical. It's not okay. That's my standard. I don't know. We all have our own standard. When I talk this way with some of my friends, and they think it's old school, but I'm still old school when it comes to patient-doctor relationship.
Yeah,
I don't know. Yeah, maybe you should add what you want in boundary setting.
yeah, no, sir. What you said has also covered for that. Just to add more to it, that you used to emphasize the need for supervision, also for the therapist, and I think maybe that may
Yes, yes,
also
yes,
guide.
yes. Okay, yes,
Sir.
okay. That's it. You notice I said that self-analysis is not a once-on thing. It's a continuous process.
Yes, sir.
It's not that you've reached this level and you are not in a relationship where one can tell you what you're doing with yourself. You understand that? In TED lectures, I don't know what TED God knows what. The surgeon, even after being surgeon for a long time, invited an old colleague of his to attend his sessions for like 6 or 10 times. And after each session, the person he spent an hour each time. And the things he always had taken for granted, the independent assessor sort of was able to pick them out, and it made this surgeon a better person. So in analysis, you always are in a relationship where if you have someone analyzing you or able to talk about you, that having such an arrangement. I have some older colleagues. Many of you hear how I talk with Jude and we make fun and things. Deep down things I share with him, and you understand. You need to have someone in relationship with who can talk you down and say the truth about you. If you don't, you are not okay. I think in substance use we call accountability partners. You need it. at the heights of your, not even the height, you don't need to reach a height. You should have people. So it's not just supervisors now. Someone is
Peers,
not a
peer
supervisor.
supervision,
Yes.
peer
But
supervision. Yes.
in training, there is supervisory. You can have supervisors in training. Thank you.
Thank you very much, sir. I don't know if the person that asked the question, if that has addressed the question. While the person respond, somebody make a comment here. Uh, Dr. Motolani Oyeride. The question is, can psychoanalysis be used as a one-off for a case of sexual abuse? And the further comment that Prof said psychoanalysis needs no follow-up. So that's what the person is asking. One, can psychoanalysis be used as a one-off for a case of sexual abuse?
Now, it's a difficult. You remember if someone is having sexual abuse, I don't know what sexual abuse is actually. Someone who was abused sexually, or someone who is abusing people sexually. Anyway, I'm just joking.
Yes, sir.
Because either can be. But back to the question, you know, with someone who, I don't know, the depth that, you know, I spend a lot of energy and time trying to talk with us about assessment of the patient for for sexual abuse. Sorry, for therapy. I don't know. If someone was sexually abused, are there no easier short-term therapies one can do? I think this should be first choice. Going into this kind of thing, I don't know when the sexual abuse occurred. Maybe if very early in life and it's so deeply ingrained and it's interfering with every other aspect of the person's life, you understand that. Most likely, other psychotherapies would have failed. Then, if there's nothing else, then I think one has to go through it. But it's so big, I don't know. Yeah, I assume it can, but who are you going to see the therapist who is ready to take up such a thing? That's my answer.
Thank you very much, sir. I also, of course, there are a lot of people still on this session, and their comments, their questions will also help to enrich this further. Please, we still have some few more minutes before our session is over. So please, kindly let's add more flavor to it. Thank you once again, Prof. We are most grateful. And please, for those of us that are here to register our presence, kindly let's take the vote to help show when we join the meeting and to also serve as a form of register. Thank you very much.
Maybe if there's no other quick comment, I have something. I sent a list. I asked ChatGPT to post a list of all the terms, and someone made my kind of comment.
Thank
My
you.
kind of comment. Whether we're going to go through that list, it was interesting. What I did in that list was to let's see the terms we use in psychotherapy that have their origin in psychoanalysis. Sometimes the word has evolved so much that it is now having different meanings from what the original meanings are. For example, we've talked about insight today. I've talked about resistance, transference. I didn't mention a lot of the other terms. So those terms remain. Catharsis, abreaction. I don't know whether they were even in the list that I said. But many of the things that we talk about, the meaning has changed. those deep down psychoanalytic core meanings have changed. They don't mean that anymore. But those meanings, the psychoanalytical meanings exist. And if you are doing psychoanalysis, those meanings are to be reached and attained. We talk about insight and say, the person has insight, and we all talk about it. And many of us never knew that insight in this context came from psychoanalytic school, and it has clear-cut meaning. So if someone is asking you what's insight and you are in psychoanalysis, and you mention what insight is in regular psychiatry or psychotherapy, it's fun. That's it. Dr. Dola, back to you.
Thank you very much, sir. I think our time is. Thank you for making it very well spent. It really fulfill our needs, and I'm sure there will still be more on this series because psychoanalysis seems to be the most enigmatic of all the therapeutic modalities that's available to learn, and it's quite challenging. And being one of the first, the rootedness that it has and where it points to and how it helps to value the mind. There's still a lot to be learned from it. And we thank you once again very much, sir, for taking up this responsibility. And I'm sure there will still be more you give us on this as time goes on. Because the series on this is just the second one. I'm sure there is still more on the series to come, especially relating to psychoanalysis and the psychodynamics generally. I want to, apart from thanking you, sir, to thank everyone that have taken time to also be available here. And next week, when we take a break because of the possibility of clash of a coming of a public holiday related to the big Salah celebration. So please, we'll take a break and we'll continue after next week. So that's next week Saturday. We won't have any session until the upper Saturday that follows it. At this junction, I will thank our father who has helped us to keep the training ongoing, and the hopefully in the next couple of weeks or months time we'll move into the modality aspect, and everybody as we fill the updated questionnaire for us to show where our interest will be like, and we are going to be clustered into that so that we can now begin the modality, focusing on specific modality training to meet our needs and build our capacity in it and get supervision at the end of it. So all this I've been planning to see that we achieve this, and that will also require some more uh, responsibility from our side too, and that will be communicated in due time in order for us to be able to achieve and actualize this along the line. At this junction, I will call on our father to uh, end it for us as usual. We are most grateful, sir. Thank you, Professor Udofia, sir.
Yes, thank you very much for. Okay, I thank Professor Dofia for. I always thank people who do the presentation. So, yeah, so the lesson for today is whatever therapy you're going to do, understand yourself. And until next fortnight, when we're going to stay again and look at it, we should, like Tajik said, there are core areas, three or four, that each member is expected to understand and have a working knowledge, not just working knowledge. Patients you see who need to do, what's that thing called? Patients you see who need psychoeducation, all of us who are registered should be able to do psychoeducation properly. All of us should be able to do supportive therapy properly. There are two other areas that the cognitive CBT, each of us should be able to do properly. And maybe one insight oriented therapy. Those four things each of us must be able to do properly before getting mastery into one or two areas you want. So from when we finish this series of lectures, we are going to break into groups for those therapies and rotate so that in the 3 or 6 months you